history of living with obesity, but I was a caregiver for my mother who lost her battle to obesity at the age of 69. And so when I was very young, I was her patient advocate, and I was also her translator because she didn't speak English. And as a child, I witnessed quite a bit of bias, fat shaming, scaring, but I didn't know that it was inappropriate, and I didn't know that it was actually driving her further and further into her disease. So this work really is quite personal to me.
Wonderful. So how does this play out clinically? I'm so sorry you were subject to that. And today we're going to talk about what are the effects of being subject to bias and stigma in the conversations. Just very quickly, these are our disclosures, both myself and Sandra, and these are our objectives. Please note in the first objective, recognizing not just recognizing, but addressing stigma. How are we going to do that? How are we clinically in our practice going to address stigma? We're going to show you today a little bit about that in a very active role-playing process to make this a little bit more fun. Number two, it becomes about the relationship and the conversation, utilizing the appropriate language and communication strategies when focusing on obesity with patients to foster this empathetic relationship. How do you do that? Well, we're going to be demonstrating that today too. And then finally, really when I talk, I would phrase that last objective, implementing these patient-centered care approaches to set realistic goals. I'd say, how do you empathetically and appropriately kind of end on homework that the patient might choose themselves to do? We're not telling them what to do, but how could we help a patient decide on some homework between our visit now and our next visits? And so certainly I won't spend too much time on this. We know the new guidelines have focused on people living with obesity and how they face substantial bias and stigma. And I am the proud author with Michael Vallis of the behavioral chapter. Of course, medication and surgery, people generally know those two pillars. And of course, diet and exercise are not there because one of the key parts in our behavioral chapter was, this was the first time we had ever read this anywhere when Michael and I put this into our behavioral chapter. We suggested that changes in eating and changes in exercise can be considered outcomes of treatment. And that's why they're not here. If behavioral therapy and medical therapy, for example, or surgical therapy are working, patients are able to make sustained changes in their eating and their exercise, which moves us all the way from the eat less, move more, right? Just like we don't tell patients to, with depression to cheer up and snap out of it, or patients with asthma to breathe deeper and cough less. We don't tell patients living with obesity to eat less and move more. And we'll be framing all of this in a little bit of a crash course in the basic concepts. Everything's lifted from the Canadian Clinical Practice Guidelines behavioral chapter. We're going to be framing our conversations in motivational interviewing techniques. The techniques of ALSE, you might have heard it called: ask, listen, summarize, invite, and inform. And so we're going to jump in, and Sarah's joined me in my clinic, and this is an early presentation. Sandra has presented, wanting to ask about her weight. I've still asked permission if that's okay, and she has said yes. And I'm simply opening the conversation by saying, tell me more what brings you in and what it is about weight that you'd like to talk a little bit more of. I'm the physician, and Sandra's the patient. So tell me, Sandra, good to see you again. How can I help? Tell me a little bit more about what you were interested in discussing around weight or weight management.
Yeah, so what brought me in today is that I'm at my heaviest weight ever. And this all started a couple of years ago. I was starting a new job, and so I started a commercial diet program. And during that 6-month period, I was able to lose 50 pounds. I was elated, excited, started my new job, and then a rebound started. And not only did I gain back the 50 pounds, but I gained an additional 50. So 100 pounds in about a year and a half. And I have to tell you, that was one of the most humiliating experiences of my life, because I could see the reflection in my coworkers' eyes as I would show up to work month after month, heavier and heavier. And it started to affect my mobility. I live with chronic lower back pain, so I can't really move as freely as I want to. I'm starting to isolate from my friends, from family, from activities. I don't participate in much. My mental health is taking a complete nosedive, and I'm thinking about doing a sick leave just to kind of catch my breath for a little bit. I would have to say my weight right now is just unmanageable, and I do not have another diet in me. I've been dieting since I was 15. I get it now, like it only leaves me heavier than when I started. And even when I try to control myself, I'm overwhelmed by cravings. They're very intense and immediate, and I just feel unmanageable.
So Sandra, first off, thank you very much for sharing. You described quite a significant experience of you struggling with your weight, and I want to thank you for sharing that with me. What I hear you saying, and as I jump into this, by the way, you are about to hear what I'm going to suggest is one of the most powerful tools that you'll ever have in clinical medicine whatsoever, certainly obesity medicine, which is called the summarize. You've heard the ask, you've heard the listen, and now you're going to hear what we call the summarize. It leaves summary out of your clinical practice at your peril. Sandra, what I heard you say is you're at your heaviest ever. And this really all started a couple, correct me if I'm wrong, what I hear you saying, and I really want to make sure I have this right, is that this kind of started a couple of years ago. You started a new job, you started a commercial program, you lost around 50 pounds of weight, you described, and you said, you endorsed feeling elated and excited about that. And then there was really what you describe again as a rebound. You gained 50 pounds and then another 50 pounds. And then you describe it as humiliating. It felt like a very strong kind of negative experience I started to get from you. And you could almost see the reflection in your coworkers and how they were looking at you, right? And this was affecting you, it was affecting your mobility, and even you described an isolating effect, kind of almost removed more or withdrawn from friends or family. You endorsed that your mental health really took a nosedive. You're even considering sick leave, and you describe your weight as unmanageable, and really kind of don't plan on taking another diet or starting another diet because you really see that just leaves you heavier. You're overwhelmed by cravings. I wanted to make sure I had what you told me kind of correct. Is that about correct?
Yes, and I'm just gonna go off script for a moment.
Sure.
I feel so emotional hearing you say that back to me because we didn't actually rehearse this, and so I have to tell you, like, I'm almost moved to tears because I don't think anyone's ever repeated my story back to me in that way, and it's very shocking to be emotional in this moment, even though it's in retrospect. So wow, this is
Thank you for sharing that too, and that's the power of the summary, because how many times has Sandra been in a healthcare practitioner's office where she told her story and the person said, okay, well, let's talk about some diets then, and let's go on to solutions, without actually confirming that what Sandra said was heard, was listened to via the method of summary. And often what I find in clinical practice is once you summarize, someone realizes that they're being listened to, and then they'll share more, right? They'll say, oh, well, another thing then, now that you're listening, they won't say now that you're listening, but they'll add more, right? And so, in the back of my head, this is what's going on in this initial presentation. You see, I know, as we've discussed today, that obesity is understood to be a real disease. 70% we know of someone's risk of struggling with weight in their lifetime is conferred genetically. And we know that the absolute great majority of these genes are in the central nervous system. We inherit, as you've heard today, this unique appetite system with 3 layers, with the executive system and the reward or motivation or hedonic system, and then the homeostatic system at the bottom. And these 3 layers developed for an environment where work was required for food. No one worked for their food today, and you take that for granted. But human experience was always that we needed a motivation system that made us work for our food. We needed to be motivated to go. So here in this weight system is where our weight is regulated, our cravings, our motivation to food. And finally, of course, and I always share this as bad news with my patients, this is also where our brain defends against fat loss. If there's one key bad news piece you've heard today, and boy do we need to share this with patients, is I'm wondering if you would consider that as you struggle with weight and manage weight, that your brain is expert at recognizing fat loss and fighting against it with increased appetite primarily. Yes, decreased metabolic rate, but to a much lesser extent. Increased appetite, increased interest in food as someone loses weight. In fact, we now know this is Arya Sharma quoting him, that's actually the logic of anti-obesity medications. Anti-obesity medications exist on this planet. Why? Simply to defend you against what your brain otherwise will be doing. And I also know that this ancient appetite system has collided, as Sandra sits in front of me, with what we call the obesogenic or modern food environment, where foods are hyper-palatable, as we heard earlier today, ultra-processed, ultra-portioned, ultra-available, advertised to look healthy and delivered to your front door. So as I'm listening to Sandra, not only am I listening for the details of her experience, because it's so critical, I'm also, in the back of my head, knowing I really want to communicate to this patient the following. And so we've asked, we've listened, we've summarized, and I like the phrases. By the way, the summarize is preceded by wondering, what I heard you say, correct me if I'm wrong, tell me if I have this right, as a precedent to the summary. And then we have the inform, invite, the invite, inform. We heard physicians today sitting here saying, I'm not an obesity specialist, give me an FAQ, give me what I should say, give me what I should do in these circumstances. I don't want to turn red-faced like we heard about a cardiologist earlier today when questions come and I don't know what to say. And so here is that FAQ answer, but we don't say FAQs in obesity medicine. We say inform, invite, or invite, inform, because this is motivational interviewing. So the FAQ would be, well, now I'm just going to answer your question. We've gone through the motivational interviewing process instead, and now I'm going to turn to Sandra after summarizing what she said, and I'm going to ask her just what we talked about just now. I'm going to ask her if I'm wondering if you would consider the following. Sandra, the science around obesity medicine has changed quite dramatically. We now consider struggling with weight, I won't repeat in great detail, to be primarily a genetic, brain-centered, strongly environmentally influenced, progressive, real medical condition. And would you consider, and here's the stigma, here's the countering, how are we countering internalized weight bias? I'm wondering if you would consider that struggling with weight is not your fault. I'm wondering that it's not because you have less willpower or you're not motivated enough or you're weak, but instead because you're living with a real medical condition untreated. That's unfair. And, by the way, treatment exists. We have 3 pillars to treatment, not diet and exercise, not eat less, move. There's behavioral therapy, there's medical therapy, and there's surgical therapy. Then, if I was a physician who had only 3 minutes, at this point, I would say, here's some material about obesity as a real disease. I'm wondering if you would organize a visit where you could come back and we could talk in much more detail about treatment principles. And here's the information about obesity as a real disease. And if you can make an appointment, you have a red carpet welcome to come back and talk about this. That's if it's a quick visit. And if I have more time, and if I'm shy and it's the last visit of the day, we go into more. So what I wanted to do at this point is I wanted to ask Sandy, what would that have been like if in the past you presented to a physician and that's the methodology that you heard and more about what you heard in the past?
Yeah, I think I want to start by contrasting what I experienced to really hit home how this experience is different. So when I did end up going to the doctor about my lower back pain, she said that that was not a medical issue, that was a weight issue, and that I needed to lose weight. And I was already very much filled with shame and embarrassment about my weight, and so when the question came up, don't you care about your health? I started to question if I did. Because look where I had gotten. Maybe I didn't care about my health. Or the other one, I guess she thought this was motivational. If you really, really want to lose weight, you would lose weight. You make the decision and you do it. And I thought, there's nothing else I want more than this. Like I think about it every single day. So in this contrast, I mean, for me, it starts to build rapport with the doctor, trust. It makes me feel like, okay, this could be a medical condition, but this is going to take me a while to wrap my head around. It's absolutely going to take some time because I grew up in the diet culture that it is willpower. And I had a family that said, put the fork down, and that exercise was the answer. And so now I literally have to have a paradigm shift, and I have to reconstruct how I think about myself in the context of what I am struggling with. This would definitely build trust again, and I would probably start going to the doctor more.
Oh, very cool. Great feedback. And so we see the potential shift by, as our objective said, kind of recognizing bias and stigma that's been internalized and creating this relationship and using motivational interviewing as the technique. Thank you for letting us go through that example, Sandra, pardon me. So we wanted to go through another quick one. So just to give you guys, because has this ever happened in your clinical practice? A patient comes in and says, I'm not losing weight. Doc, or dietitian or nurse, I'm not losing weight anymore. I'm stuck. Right? Is anyone's blood pressure going up as I described that, right? So let's role play this a little bit, right? Maybe Sandra, maybe if you could present and be coming back. And I've already, as you come back, just reminded you, just a reminder, thanks for coming back, but we consider struggling with weight to be a real condition, not your fault, treatment exists. Just to remind you, because I know that's not public discourse, and you won't hear that out there, but just when you're in this office, that's certainly amongst myself, amongst the staff here, that's our understanding. Real condition, not your fault, treatment exists. Tell me a little bit about how things are.
Well, things are great. I've lost a considerable amount of weight, but I have the last 30 pounds to go, and I'm not happy at my current weight. I'm actually quite frustrated. I keep doing all the things I did before, but the scale will not budge. And I can't seem to control that number, and it literally makes me want to throw in the towel. Why would I work this hard not to see the scale go down? And you know, it's not about knowledge. I have all the knowledge. I just want to know, how do I get to my goal weight?
What's next, everyone? Yeah, thank you. So what you're telling me, Sandra, and thank you again for sharing, correct me if I'm wrong, what I hear you saying is, things are great. You've lost weight, and now you feel you have the last 30 pounds, as you describe it, to lose. 30 pounds to go, and you describe that you're not happy at this weight. And also you describe it, right, and I hear you saying this quite clearly, like, listen, I'm doing the same that I was before, but I'm just not, the scale is not budging. This is the same level of effort, I'm doing the same. And I can't control the number, and I hear kind of demotivating, because you use the word kind of throw in the towel. It's creating maybe an emotion of demotivation, right? And like you said also, it's not about not knowing what to do. You know what to do. It's just how you get there. That's what you're describing. And so I'm wondering if you would consider the following. Now, it's quite rare that I'll meet a patient where I have not gone through this. I cannot imagine a visit that I have not gone through. In fact, in my initial consultation, I'll review this FAQ equivalent, invited form. I would probably, in every visit, in a very short form, review exactly what we were looking at on this slide, and this would be my invited form, and I'd ask Sandra, you know, would you consider, I'm wondering if you would consider that all weight loss slows and slows, and eventually plateaus. And it's because of this horrific, unfair, bad news that I shared with you that I feel very bad about, even personally, that the brain defends against fat loss by recognizing, by the way, losses of leptin, which our brain is super sensitive to. And in response to that, appetite goes up, and metabolic, but again, metabolic rate goes down, but primarily appetite. And so I'm actually, you know, we now talk about weight as not a behavior. It's not something, I know this will sound weird, but it's not even we think of as something that someone has control over. We say we have control over our behaviors. And so I'm wondering if you might fashion I wouldn't wait till she's in a plateau to go through this, but that's the artificial scenario we have here. And it might happen that way. I'm wondering if you would consider your path forward, framing your path forward to be a process of finding or iterating or practicing or developing the skill of really what is the least amount of calories that you can take in, the healthiest eating that you can put together that still maintains a loyalty to fun and food and friends and socialization and celebration and travel and the things that you value from fun and food or drink. And all at a level of effort that is sustainable. Why? Because whatever you put together, I don't know if this is good news or bad news, you'll have to do for the next 40 years, 50 years. So whatever you put together, in that way, you might consider it should be sustainable. And so would you consider organizing your most modest lifestyle that's still fun and enjoyable and sustainable and maintainable, a level of effort that you can keep? And then, might be the difficult part, and then just standing back and letting your brain and body tell you, how strongly are your genes going to defend against fat loss? The thing is, we don't know. It's actually a primarily genetically conferred trait. in the lower parts of our brain that we share with mice. And so, would you consider standing back in this context and doing your best and letting your brain and body kind of tell you where that lands? It's something we in Canada call someone's best weight. We've thrown out target weight, goal weight, and ideal weight and replaced it with the concept of best weight. What are your thoughts about that? I know it sounds a little upside down and maybe difficult, but what do you think of that as a concept?
So it's a difficult pill to swallow, but I think what would be helpful for me is when I came to the clinic if they didn't want to take my weight. Because when I walk into a clinic and I'm asked to step on the scale first, that signals to me that that is actually the most important marker. So I would like to skip that completely out of the equation so that when you and I talk, I won't have that number in my head that won't allow me to hear anything that you're saying because I'm disappointed in the number. And then we can only focus on the ways that I'm improving outside of that number.
I really like that idea because what Sandra and I were talking about earlier, first of all, I, by the way, won't weigh patients, and we work remotely, and patients, if they wish to report their weight or even get on a scale and take their weight, that's very much up to them. In fact, we tell them if you anticipate that getting on a scale might create a negative emotional response, please consider not jumping on the scale, because what Sandra and I could be talking about, remember how she started this interview? She actually said things are great. Which means that there's probably quality of life and health benefits going on, and we got distracted by talking about, well, I had to go through best weight principles because maybe we hadn't covered it, but certainly I think you had mentioned this earlier, would really appreciate discussions about benefits that you're experiencing from quality of life and health, and starting to bring those to the surface.
Yeah.
Right. So, again, I would provide information around best weight and the brain's fighting against fat loss with increased appetite and decreased metabolic rate, the concepts of best weight in more detail, and invite her to come back and talk about the health benefits that she's experiencing, the quality of life benefits that she's experiencing. There's many other areas, there's only 6 other areas. In our guidelines, we've created a knowledge translation. Michael and I, just recently, last week, Michael Vallis and I reviewed, and we are now committed to creating more of a formal knowledge translation as the expansion of the behavioral chapter in the Canadian guidelines. And these are 2 of the 8 components that will come out of that. How to address internalized weight bias and how to address expectations. And there's 6 more. You'll have to invite me back for the rest.
Stay tuned.
And so, one last point. So to warm up, we're the last visit here. If everyone can warm up, I'd like you to just point with your arm to the largest truck on the screen. If you could all point to the largest truck on the screen. Okay, great. Now, my next question is, are you sure? Are you sure you pointed to the largest truck on the screen? Yeah? Take your hand and look at the size of each of them. What you're going to recognize, and you'll have to take my word for it, it could be on the screen. Usually with a patient, it's on their computer screen if I'm seeing them remotely. But I can tell you without a doubt that each of those trucks are the same size. So why am I showing you this optical illusion? By the way, cognitive, according to Daniel Kahneman, who just passed away, kind of one of the great psychologists of our time, cognitive illusions are even more powerful than visual illusions. This is a visual illusion. Cognitive illusions are what Sandra has prevented us with today. She has an automatic set of thoughts that came to her when she got on the scale and didn't see the results. She had automatic thoughts coming to a doctor to talk about her weight. Why I showed this photograph is because I'm going to invite all of you to consider humility. Just because you told the patient this is a real disease, not their fault, and treatment exists, and about the concepts of best weight, that is not going to be, Sandra, you said it perfect. This is going to take time for me to wrap my head around. There will never be a time in your future that you look at this photograph and that the first impression is not that the one in the back is the biggest. There's nothing you can do about it. It's a trick in your brain. But you now will have a second line of thinking which says, oh no, I've seen this, Macklin put it on the stage, they're all exactly the same size, this is an optical illusion. That's cognitive restructuring, that's cognitive behavioral therapy. To have an automatic line of thinking and help the patient know that they have an automatic line of thinking and that their work isn't to get rid of it. You guys were never going to look there and think that they're all the same size at first, but you will at second thought. And that's cognitive restructuring and cognitive behavioral therapy is Sandra will slowly learn that these automatic thoughts that she's subject to when she gets on the scale, or if she sees herself in the mirror, or if she has an off-track day, or if she's presenting to a primary care physician about weight, the first and automatic thoughts, it's natural that they come, they never go away. So I wanted to leave that as a humiliating, rather a humbling kind of concept. Please, as practitioners, understand this has been years and years and years of lived experience of being the target of stigma and bias and discrimination. And you're not gonna, that's not gonna go away right away. So that's why repetition is such a critical part of the behavioral chapter. And I wanted to close by leaving Sandra a little bit of time to kind of talk about, again, the contrast in experiences between, let's say, a progressive clinician in obesity medicine versus what you've experienced in the past, and any final thoughts about that?
Yeah, I think it's, just to go back to the scale, and right now I'm a patient advocate, and I feel like I know so much in this space, and I advocate for people and myself, but there are still times that I sit across from a doctor wearing a white coat where I somehow lose my voice, and I'm not able to ask the questions, or I'm not able to challenge. And I remember seeing a doctor just recently, and she's like, oh, I need you to, you're a new patient, I need you to hop on the scale, and I said, no thanks. And she got really upset with me. And I just, this idea, it's my body, my choice, and I felt in that moment, I didn't need her to know at that time. There was another time I did it at a hospital, and I said, I'm gonna turn around because I don't wanna know. And she said, that's fine. And then she told the nurse beside her my weight. I'm like, I can hear. I might not see it, but I can hear. So just letting, I think what's really important is empowering patients. Making it feel like a partnership so that it doesn't feel like I'm being told what to do. Knowing that I also have some knowledge that yes, I'm struggling in this area of my life, but I may have success in other areas of my life, and making me feel important. I think one phrase that you used when you were paraphrasing, summarizing to me was, it's really important that I get this right. I think that's what got me very emotional, to hear that it was important to somebody to get my story right, and to want to hear my story, because I'm more than a disease called obesity. I have a story. I want people to understand how I got here, what is unique about me, what is unique about my journey, what's nuanced about me, and have me be treated as a whole person.
Well, thank you, Sandra. Much appreciated. Yes, really appreciated. So we see that patients have automatic thoughts, bias, and stigma regarding their struggle with weight and their ability to lose weight. And here we've demonstrated using motivational interviewing to foster this kind of supportive, especially the summary, right? Yeah. Miss the summary at your peril, right? Right? That's a take-home message for sure. And we kind of demonstrated how to implement a patient-centered care approach by leaving homework and leaving Sandra to decide, and inviting the patient to consider, one, that obesity is a real disease that's not her fault and treatment exists, and finally to consider the neurobiology of obesity and how the brain defends against fat loss, and the overarching best weight concepts that we can share with patients as an invitation, inform, kind of the equivalent of what we were hearing earlier about a FAQ, right, that clinicians can benefit from. So thank you for your attention.
David Macklin, will you allow me to add one more key message? So there is something about the energy that a clinician brings into the room, and I found this clip of Dr. Macklin and the way that he often comes into clinic that I think will be inspiring for everyone. If we could play that clip for everyone to see. One more time, yeah.